Hi, everybody. I am Nicole Lieber. I am grateful to be here. Those were all my qualifications. They were listed earlier. They make me sound much better on paper than I am in real life. But I am board certified in addiction medicine, and so I spend all day treating addiction and addicts. So the reason that I'm doing the talk that I'm doing today, the neurobiology of addiction, which is basically Addiction 101, is there's a couple of reasons. And I want you to know that I do the same exact talk for physicians, healthcare professionals, communities, judges, police departments. Everyone gets the same basic information, and the reason is because nobody understands it. Nobody understands addiction. We call it a disease. We put this stamp on it, and we say this is a disease. But then nobody bothers to tell you why it's a disease. And when that happens, what we wind up with is a stigma disguised. And people say things like, sure, it's a disease, but it's not as bad as like cancer, right? People say things like they hear a news article about parents who overdosed and died, and they had a little kid, and they say that kid is better off without having to grow up with those parents. What I don't hear is about a kid whose mom was diabetic and decided she was going to eat chocolate cake and not take her insulin and have a diabetic seizure, go into a coma, and die. I don't hear about how that kid is better off without her parents, because they died of a disease, so did the addict parents. So if we don't understand why this is a disease, then we don't have the right to call it a disease, and then we have no idea how to treat it as a disease. So that's why I do this. When I'm done, everyone in here will be as well-versed in addiction brain information, and I promise it'll be easy enough that you can understand it. You will know as much as any doctor that I know that's not in the field of addiction. So, in medicine, in order for something to be a disease, it has to fit into the medical model. Back in the day of the Greeks, they used their medical model was called like the humoral model, where they used to like drill people's skulls and let demons out, and they would do bloodletting and weird things. That was their medical model. That was how they functioned. That's what they believed was how you treated diseases. Today we use the disease model. It's a little bit more advanced. And essentially what it says is in order for something to be a disease, there's an organ, there's a defect in that organ, and there are symptoms because of that defect. So in the example of diabetes, like I said earlier, the organ would be the pancreas. The defect is a decrease in beta islet cells. The symptoms are high blood sugar, coma, eye disease, etc. In an acute disease, a broken bone. That's an acute disease process. The organ would be the bone, the femur bone. The defect is the fracture, and the symptoms are screaming, bleeding, deformity, whatever. So the question becomes, how do we fit addiction into this model? Because if we're going to say it's a disease like cancer, it has to fit in the same model we use to call cancer a disease. So addiction is a brain disease. It is not a psychological illness. Okay, there are definitely psychological components to it, but it is not a psychological illness, and it is certainly not a moral failing. It is a neurological illness. So we're already starting at a disadvantage because nobody understands the brain really that well, not even brain specialists. So what we know is that when people who have brain tumors or some kind of lesion or damage in their brain, a lot of times they behave badly. Their personality changes. They act impulsively. They don't set goals anymore. They're unkind to family members. And then we find out, oh, they have a tumor, and we all say, oh, well, we feel bad for him because he's got brain cancer. And we excuse the bad behaviors. But the reason that they behave badly is because they have a disease in the brain. The symptoms are the behaviors. There's two parts of, well, there's a lot of parts of the brain we deal with in addiction, but the two parts that we're going to learn about tonight are the frontal cortex and the midbrain. And they're the two most important parts. The frontal cortex is the part of your brain that makes you you. That's where all your superpowers are. That's why I use Superman to represent it. That is the part of your brain where your thoughts are, your feelings, your emotions, your values, your ethics, your morals, your willpower, your choice, your ability to set goals and plan and rationalize. That's all your frontal cortex. And when it's working properly, like presumably everybody in this room, it's a fully functioning superhero. When it's not functioning, it's like kryptonite Superman. The other part of the brain is the midbrain. The midbrain is very primitive. It's deeper inside the brain. It's one of the first parts of the brain that evolved, and it's kept us alive for thousands of years. That's why you're all here, because of your midbrain. Your midbrain, I use a tiger to represent because it's very primitive. The midbrain has no ability to think. It doesn't weigh consequences. It doesn't set goals. It doesn't look at the future. All it does is keep you alive. That's it. Its whole function is to keep you alive. Life or death processing right now. Everyone in this room right now has a sleepy tiger midbrain. Nobody in here feels their life is threatened. Oh my God, it's my #1 groupie right there. Woo! This angry tiger is a midbrain that feels threatened. The midbrain has 3 functions. Okay. Eat nutrients and drink water, kill off a predator or run away, and procreate. That's it. That's all it does. Okay? When a baby is first born, one of the first things we do is we feed it. And the reason we do that is because feeding it, giving it nutrients, sets off the reward system in the midbrain. And the midbrain then knows that nutrients are necessary for survival. The baby becomes addicted to food. It's necessary for survival. In cancer, all we have is an overgrowth of normal cells that get out of control and aren't kept in check. In addiction, we have an out-of-whack reward system. It's necessary for survival, but it gets wacky when we use drugs. Drugs work in the midbrain. And drugs, when I say drugs, I mean all drugs that people abuse, so that includes alcohol. And they're all the same. Marijuana, alcohol, heroin, crack, crystal meth, Xanax, anything that can be addictive, they are all exactly the same, and I'm going to explain why. Drugs work in the midbrain. If you take a probe, little probe, put it in a mouse brain, and you put it right into the cortex of the mouse brain, and you allow them to hit a lever that would push cocaine through that probe into the cortex, the mouse would not hit the lever. They don't care about the cocaine. We know because for years in the 50s, up to the 50s, we thought drug abuse was a cortex problem, right? It was a personality problem. These people just had bad morals or ethics and made bad choices. So we assumed it was a cortex problem. So they did this experiment. What they found, though, was when you push the probe deep into the midbrain of the mouse would then hit that lever to self-administer cocaine to the point of death. It wouldn't play with other mice. It wouldn't eat. It wouldn't do anything else except hit that lever until it cocained itself to death. And most experiments we do on animals or even with people with drugs are with cocaine because it's very short-acting and has very quick onset. That's why, not because we don't want to know what other drugs do. But essentially what we know is they all do the same thing. So mice get addicted. Mice will use cocaine to the point of killing themselves and ignoring everything else that they're supposed to do as a mouse to use that drug. But mice are not from bad homes. Mice don't, join gangs or whatever. So what happens with repeated use of drugs? And drugs release high levels of pleasure chemical. They release a high level of dopamine. I'm going to explain that. But using anything that releases a high level dopamine is going to cause a change in the midbrain, which essentially looks like this, a hijacking. The midbrain, programmed for your survival, now believes it needs high-level dopamine, which it can only get from drugs, in order to survive. So the addict is not thinking, I need drugs to survive. The addict's subconscious brain that they have no control over is saying, I gotta get some dopamine quick or I'm gonna die. It's wrong, but that's how neurologically it's changed. So for people who are not addicted and who can't understand, if you were in the desert and you were on day 5 with no water, your organs are shutting down, you are about to die of thirst, and I offer you a bottle of water, but I say, if you take this water, I am going to take your kids and your job and your house and your bank account. There is not a person in this room, on earth, anywhere, who could refuse the water. You're biologically incapable of refusing the water. Now, I'm sure everybody here loves their kids or parents or jobs or bank accounts or whatever, but you would give it up for a bottle of water. And the reason is because the part of your brain that values your kids and your job and all that stuff is your cortex. And during times of survival, or where you need to survive, the midbrain is on and the cortex is off. So the part of your brain that values those things is not even working at the moment. So you drink the water, your tiger gets sleepy, you satiate the midbrain, and then your cortex comes back on and goes, I can't believe I just gave up all that stuff for water. And you're going to start thinking of ways you can manipulate me into giving you back all your stuff. I put this in here because everybody likes to tell me about somebody they know, I call him Uncle Marty, who says, I used crystal meth every day for 10 years and then I just put it down and I walked away and I never used again. All you need is willpower. You just need a strong mind. That's all you need, right? I hear that all the time. That's what every addict wants. Well, two things. One, you have to have a gene to be addicted. You have to have the gene for addiction. 90% of the population, I just made that statistic up, but it's really high. A large percentage of the population has the gene, okay? That gene has to be turned on, activated, in order for true addiction to be present. So Uncle Marty either doesn't have the gene, never activated the gene, or has switched to alcohol and Percocet for his gout, but doesn't think that those are a big deal because they're legal, okay? Willpower is in the frontal cortex. It's not in the midbrain. So you can't use willpower to fix the broken part of your brain somewhere else. Willpower works like this. If I'm sitting at a traffic light and it's red, I physically have the ability to go through that light. I can hit gas. I can go. But willpower tells me no. I'll cause an accident. I could die. I could hurt somebody. It's illegal. I could get a ticket. As soon as the light turns green, though, it doesn't matter how much willpower I have. I could have all the willpower in the world. I have permission to go through that light. That's what happens in addiction. So willpower is useless when the time of craving comes on, and I'm going to explain that. So if I take Uncle Marty, let's say he doesn't have the gene. Let's say he never was addicted. He just used crystal meth every day for 10 years because he's that kind of guy. So we put him in a brain scanner next to a true addict, and we show them each their drug of choice. Uncle Marty's cortex lights up because he's thinking about the drug. He's thinking, oh my God, this stuff's awesome, I love it, it's so fun. Or he's thinking, oh my God, this stuff's terrible, it ruined my life, whatever. But he's thinking about it. The true addict cortex, dark, shows no activity in a brain scanner. But its midbrain, bright. Like this. So somebody who's using cocaine, somebody who's not. See all this red in here? That is active cortex. So this is not so active. And you can see that this lack of activity persists even 100 days abstinent. No drug use for 100 days. Brain cortex still isn't working that great. Superman is still pretty weak. Here's the midbrain. So in the midbrain, the red is dopamine receptor availability. So those are dopamine receptors, okay? You can see in somebody who's addicted, then it doesn't matter which drug, they have way less dopamine receptors. So what does that mean? What does that mean, Dr. Labor? I'll tell you. Addiction is a broken pleasure sense. It's a dysfunctional reward system. So again, we need that reward system to survive, but when it gets dysfunctional, that's when we have addiction. So this is how your brain works in as easy terms as I can think of it, for my sake, not yours. So you have a bajillion, I don't know how many, but like billions of neurons in your brain, and they all communicate, and that is how you function. That is how you think, that is how you breathe, that's how your heart beats, that's how you walk, it's how you make decisions, how you fall in love, it's everything. So what happens is a signal comes in from the environment, whether it's electrical in the form of a sensation, light, sound, touch, whatever, or chemical in the form of food or drugs. They come in and they bind to this first neuron, and then the neuron releases chemical into this area called neurotransmitter. And the neurotransmitter you made in your own brain. Every day you make neurotransmitters, tons of them, different kinds. You make them, you store them in these little vesicles, and then some signal comes in and you release them. And then the neurotransmitters get bound to this other neuron and exert the signal. So what does that look like? I'm walking along and I see a hole in the ground. So my eyeball receives a signal from the light and refractive light and however that works, physics, people. And it comes into my eyeball and it goes into my brain, and the electrical signal stimulates this neuron to release some neurotransmitter like acetylcholine or something, right, one of those. And then that neurotransmitter binds here and says, take a step. And I take a step. That's how our brains work. That's really simple. Obviously, that's going on like a trillion times a second. Okay, but what this means for us in the world of addiction is that it doesn't matter which drug you use, it's the neurotransmitter that's causing the problem or the effect. So if I use heroin, and there's a heroin receptor right here, and I use Xanax, and there's a Xanax receptor right here, and cocaine over here, and alcohol over here, and whatever, crystal meth over here, the drug comes into the system and it binds at its respective receptor, and it dumps dopamine into the synapse, and then dopamine exerts the effect. So for some people, stimulation or sleepiness or whatever you're feeling, okay? So what this means, this is really important, okay, is it doesn't matter what the drug is. Addiction is dopamine addiction. There's no heroin addiction. There's no alcohol addiction. There's no speed addiction. There is simply addiction, okay? Because what you become addicted to is the high-level dopamine. This is really problematic because we like to focus on a specific drug. I heard it here tonight. I hear it all over the place, opiate epidemic. 22 years ago, there was an epidemic of cocaine addicts dying. They were brought into the ER with needles in their arms, dying all over the place. Pregnant women, babies dying. It was an epidemic. We focused on cocaine. How are we going to get rid of cocaine? Crack down on the cocaine dealers. 15 years ago, crystal meth. Everybody remember all the farmers were complaining because their ammonium nitrate tanks were being stolen and people were blowing themselves up at crystal meth labs. So what did we do? We put Sudafed behind the counter at Walgreens so you can't access it anymore. We focused on the drug. 7 years ago, people were eating people's faces off in bath salts epidemics. So we made bath salts illegal. We took them off the shelves at the truck stops and drugstores. We have to stop focusing on the drug and start focusing on the addiction because it's the same disease. And the disease will continue to come back until we treat it. And it will just come back in new forms because the brain wants dopamine, the brain will have dopamine. The brain has 10 perceptual systems. Everybody knows 1 through 5. Hearing, smell, taste, touch, all those. The other ones, maybe you know about. If I'm driving down the road at the, I heard there's a judge in the audience, 65 miles an hour, the road is not moving at 65 miles an hour. Why? Because my brain is able to compensate. Why, if I feel like going downstairs into the basement and not turning the lights on, am I able to find the step with my foot? Proprioception, because I know where I am in space. That's my brain. Well, one of the systems that my brain has is this pleasure system. And the reason it's there is because I told you, when a baby is born, we have to feed it and essentially get it addicted to food so that it will continue to want to eat to thrive. But aside from that useful function, imagine going through life without ever experiencing any joy or pleasure at all. Nothing gives you joy. Nothing gives you pleasure. Why would you want to live? It's necessary for survival. And the reason that we love joy and pleasure is because of dopamine. Dopamine is the #1 neurotransmitter associated with pleasure. We love dopamine. You all love dopamine, every one of you. Some people eventually need more dopamine. So what happens is you have a set point in your brain. Everybody does. So just like you have a temperature set point, everyone in this room right now, presumably nobody's sick. Don't get me sick if you are. Everybody's at 97.6 degrees Fahrenheit, something like that. That's where you live. That's where your body's happy. You get exposed to a bacteria or a virus. Your body raises its set point, its temperature, to 90 or 101 degrees because it knows it will kill the bacteria or virus at that temperature, but it won't kill you for a couple of days. So then bacteria is gone, and the temperature goes back to your normal 97.8 or whatever. That's a fever. That's what your body does. You have a set point for pleasure. We all do. And that set point for pleasure says some dopamine is released, and it's enough to cross this threshold, which makes me think, yes, I want to do that again. Anybody here like their family and go on vacation with their family? It's got to be, yeah, okay, so there's a few of you. Anybody here, I hear people do. So anybody here go on vacation with their family to the same place every year? Yeah, okay, so we've all heard of that, right? Why? Because you went and had such a good time that that enough dopamine was released that it crossed the threshold. And so you said, this is awesome, I want to do it again. So getting a promotion at work, winning the lottery, kid gets on the honor roll, these exciting things happen. That is enough to cross the threshold. Now, I might get dopamine release from eating like a McDonald's cheeseburger, but it's probably not enough, well, for me, maybe, but it's probably not enough to cross this threshold. So it's not something I'm going to need to do like every day. The problem is when you use drugs, that's a lot of dopamine, well beyond what the threshold is for any normal person. So what the brain does is its amazing way to compensate for this is it says, we have all this dopamine in our brain. We don't need all these receptors for it because it's always here. So it starts taking away receptors in the midbrain. So we have a decrease in the receptor availability. So what does that look like on paper? The threshold moves up. When I take away dopamine receptors, you now need more dopamine just to feel the same amount of pleasure. So when the threshold moves up, you still get the same amount of dopamine from these things that you used to enjoy, but it's no longer enough to cross the threshold. Anybody here know an addict who used to love to do something? Used to love to play the guitar, used to love to play sports, used to love to hang out with these people or do this or do that. But since they've been using, they just want to be by themselves, they only want to hang out with one group of people, they don't seem happy. Anybody know an addict who was first getting clean who seems really depressed? Well, that's because they are. They have no ability to experience joy or pleasure from normal things. The only thing that releases enough dopamine for them to feel joy once this threshold moves is the drugs. And remember, when the midbrain thinks it needs more dopamine, it thinks it's dying. And so it triggers the response that we're dying, we need to get more dopamine. Stress is very important in addiction. It's very important for a couple of reasons. Stress, chronic severe stress, releases a chemical called corticotropin releasing factor, CRF. It's on the quiz. Everybody write that down. Just kidding. So as CRF goes up, dopamine receptors go down. Well, gosh, that sounds like something I just said 2 seconds ago. Dopamine receptors go down when I use a lot of drugs. Dopamine receptors go down when I have high levels of stress. Now, what is the relevance? 1 out of every 4 addicts has a history of trauma. So trauma can be something severe like sexual or physical abuse in childhood. Trauma could be something like living in a single-parent household where your parent had to work all the time and you were by yourself a lot and didn't necessarily develop the proper coping skills but you seemed well adjusted, so nobody bothered to see if you needed any kind of help, right? So it's not always something very grossly obvious. Stress, trauma could be something like a really nasty divorce in adulthood. That could be traumatic. So when you have chronic stress, you have this decrease in dopamine receptors, which looks like this, the exact same thing. So let's take somebody who is a kid who did have some kind of trauma, whose brain is already primed now to have less pleasure in their life, and they get exposed to a drug or alcohol. They have a drink, or they smoke some pot, or someone gives them a pill. Well, for the first time probably in their life, they're going to cross that threshold and say, oh my God, this is what it feels like to be normal. This is what it feels like to be happy. And then they start out down the road of wanting to feel that again and again, and who can blame them? So the other part of this problem is that using drugs is a really stressful life, right? So lying, trying to get money to buy more, lying to your family, living a double life, always worrying about where you're going to get it. It's very stressful. And that in and of itself is enough chronic stress to perpetuate this problem. So it's sort of a vicious cycle. So you may have had stress initially, which primed you to use, then you start using, the changes occur in the midbrain to make it worse, and now you're using because you're stressed, and you're stressed because you're using. So addiction is a stress-induced pleasure deafness, right? That's a hedonic dysregulation. That's a fancy term for pleasure deafness. So this is what happens. This is how it happens. Now, this is my disclaimer. I am not a geneticist or a microbiologist, so please don't ask me anything about genes or microbiology. This was explained to me as simply as I can understand it. So you have to have a gene for addiction. There are many genes for addiction. It's not one. There are many. And I'm going to pick on my front row here. So this person has a gene for addiction that is turned on or activated by 600 uses of methamphetamine. And this dude, he has a gene for addiction that's turned on by 8 uses of an opiate. Also, 9,000 uses of alcohol. He has 2 genes. Sorry. And then this guy, he has a gene for addiction that's turned on by 1 million uses of Xanax. So he might go his whole life and use all sorts of different drugs. But if he never uses Xanax, he will never activate the gene, and he will eventually be able to stop on his own. He will be Uncle Marty. That's Uncle Marty right there. If she uses any drug except methamphetamine, probably not going to turn that gene on. The problem is, this guy here, he had 8 uses of an opiate to activate his gene. 8 uses. So that's 1 surgery. So the second time he ever takes a pain pill, he's addicted. Once you're addicted, once this is turned on, now we have that problem with the neuron not recognizing which drug is being used, right? Because the only thing that recognized which drug was the genes. And now the gene's turned on, so it doesn't care anymore. The brain can't tell the difference. So people who are addicted to heroin, using heroin, that think, I'm going to stop using heroin and call myself clean, but still drink every once in a while or smoke pot, setting themselves up for this cycle. Nobody stays clean in the long run from that. It doesn't work. It's neurology. It's not me. It's not Dr. Labor being like, you can't drink because you're an addict. It's your brain says you can't drink because you're an addict. Okay? So this is what has to actually occur. We don't know which genes you have. We don't know if your gene is activated by 1 drink of alcohol. This is why anybody that ever did DARE in 5th grade, and they say, first time you ever huff nitrous, you can die, right? And then you see a lot of friends huff nitrous, if you have friends that do that, and then they don't die. And you think, they lied. But the truth is, first time you use anything, you could be addicted. We don't know. The other neurotransmitter I talk about is glutamate. Glutamate is the most abundant neurotransmitter in your brain, and the reason it's important is because dun, dun, it is responsible for your memory. So, glutamate is the executive assistant of dopamine. So whenever something good happens in your life and dopamine is released and your brain goes, oh yeah, we like that, glutamate is right there going, let me write that down. Let me keep track of that. And glutamate is such a good assistant that it will record information surrounding the dopamine event. So this is why go to the same bar where you used to drink all the time just to get a burger and you feel triggered. This is why you could go 2-3 months without using any drug, go to the Circle K to get some coffee, run into somebody you used to use with, and before you know it, you're back in detox. Or why driving down the street where you used to cop your dope gets you sweaty and uncomfortable and thinking about using again. Because glutamate remembers. So there are 3 things that cause relapse in humans. The first is exposure to dopamine, high-level dopamine. So again, no such thing as addiction to one drug. This happens most frequently with people who use heroin, stop using it for a period of time, go to a family function and have a beer or a glass of wine at dinner. That is one of the most common causes for relapse in heroin users. In alcoholics, they stop drinking for a few months and they get a prescription for a pain medicine. They don't like pain medicine. They're not abusing their pain medicine, but their brain doesn't know the difference and they're getting high-level dopamine from that pain medicine. And so what it does is it triggers the brain. It starts to quiet that cortex, where the good decision making is, and wake up that tiger in the midbrain and say, I think we need this. The second thing that causes relapse is stress. Anybody know an addict who was clean for a period of time and relapsed? What do they say? Someone died, something died, lost my job, spouse left, something stressful, right? And the third thing is drug cues, people, places, and things. When somebody comes into my detox and they're getting ready to be discharged and they're going home because I can't get them in anywhere, one of the things I tell them to do is rearrange the furniture in their house or apartment. Because if you sat in the same lazy boy recliner every day to drink your bourbon, or you woke up every day on the same side of the bed and you pulled out your works from under the mattress, the second you lay in that spot or sit in that spot, you're going to be triggered because of glutamate. So, brain knows it needs high-level dopamine for survival. It's wrong, but this is what it thinks, because this is the damage. So it thinks it needs this. So how does it take a soccer mom or the quarterback of the football team or the prom queen or whoever, somebody that we wouldn't associate with making these bad choices like stealing and lying and hurting people, and how does it motivate them to repeat the behavior of using? And the answer is craving. Now, craving is not like, oh, I want chocolate. Like, that's not craving. Craving is true suffering. Craving is an activation of the midbrain. So your cortex shuts down. It's like you're dying of thirst in the desert. Cortex shuts down. Midbrain turns on and says, I'm dying. I absolutely need some dopamine stat. And you develop these physiological symptoms. So sometimes you get like sweats and chills and stomach cramps, which we call post-acute withdrawal, because it can happen even 30 and 60 and 90 days after you stop using, right? But obsession. There's this obsession that comes with it, this need to feel different. That's what addicts will generally identify. I just need to feel different. I'm overwhelmed with anxiety, sadness, anger, I don't even know. But I gotta get away from it. I have to get away from this feeling. And it becomes tunnel vision. And the only thing I can liken it to is if you have children, maybe not even have them, if you see a child in the middle of the road and a car is coming down the road, that tunnel vision, that overwhelming need to get to that child to get them out of the road, that is the kind of obsession going on when someone is truly craving. It is true suffering. So once this craving sets in. So the midbrain needs high-level dopamine to survive. Wrong, but it thinks it. It motivates with craving. Once this craving sets in, how does it control? How does it control the behavior? This is fascinating. This is where the two parts of the brain actually do communicate. So this occurs during times of craving. So the cortex is quiet. It's not working. The part of your brain that makes you you, that thinks and feels and values, isn't working. It's like a library full of information about you shut down for the night. And the midbrain is awake. And it sneaks into your library like a ninja. And it goes through all your files. And it looks for the thing that it can bring to your consciousness that's going to give you that green light. It's going to say it's okay to go through this light. It's okay to use. So you know how bad it is to use. You know the damage you've caused to your family, to your life, to your health. But the midbrain knows if it gives you a green light, all your willpower is going to do no good. You're going to want to use. And it looks for things like pain. Hey, remember that herniated disc I had 10 years ago that I never bothered to have looked at again? I think it really hurts bad. Yeah, remember when we were little and we didn't want to, we got real anxious when, strangers came around? I think I still have that suddenly now. This isn't to say that pain and anxiety aren't real. They legitimately are real. But when they start coming up as the only thing that's going to help them are specifically drugs that people abuse, we know that that's not the primary problem. If somebody says to me, I have terrible anxiety, it's horrible, the only thing that's worked in the past is Xanax, but I'm willing to do whatever I have to do to help my anxiety. And if that means I have to go to therapy 4 days a week for 2 hours a day, that's going to kill my ability to work, but I'll do it because my anxiety is that bad. Not addicted. If they say I have really bad crippling anxiety and nothing takes it away except Xanax, so that's all I'm going to try, probably not anxiety so much as addiction. Pain doesn't kill anybody. Nobody dies of pain. It's not to say addicts don't have pain. It's to say they need to be willing to try every other modality to treat that pain with the understanding that none of them are going to work as well as the opiates. They're not. But you can function. Stress, my job sucks, my wife sucks, whatever. Somebody sucks in my life, right? Find some excuse to use. If you're looking for excuses to use, and the problem is, as the addict, you're not going to see it because your cortex isn't functioning properly. But who will see it? People around you. When your family or your friend says to you, we're worried that you're so fixated on this pain, anxiety, stress issue, that's probably because it's a problem. And then we see this, right? So now I have a reason, my pain, my anxiety, my stress, my horrible life. Now I'm totally justified in these behaviors. I have to go to 14 different doctors to get pain meds. Nobody's treating my pain, and it's real, and nobody cares, and they're just treating me like an addict. So it's not my fault that I have to go to 10 ERs a week. It's not my fault that I had to steal from my grandmother, but she wouldn't just give me the money, And these become truly justified in the brain because, again, those reasons were brought to the surface by the addiction. And then, this is the hardest part of all. Once the drugs have gotten hold and the change has occurred in the brain, now we have a problem with just the behaviors themselves being addictive. And anybody that's ever used needles will tell you that they start to feel better. They start to come out of withdrawal before they ever get the drug in the system. Just getting ready to use is enough to start making them feel better. So it's the behaviors. Sleep medication. Over-the-counter sleep medication. Is it addictive? No. Does it release tons of dopamine and cause changes in your brain? No. Is taking a pill to fix a problem that could be fixed behaviorally addictive? You bet. And we encourage that in this society left and right. Don't believe me? Turn on the TV. Wait for 2 seconds. You'll see one of the drug commercials, right? Hey, you got a problem with X? Take this drug. You'll have a problem with Y and Z and A through K, but we'll fix that X. We see that a lot. We encourage people. Oh, you got a problem? Fix it. with this pill, fix it with a chemical, fix it instantaneously. And that becomes, for an addict, that's dangerous. For an addict, that becomes part of the drug, the whole culture. So I tell my patients, they say, well, can't you give me something for sleep? I don't sleep well. There are 11 people on earth, I'm not sure if that number's right, but I know it's less than 20, who have polyinsomnial familial disease, which is the disease where you can't sleep and you die. Nobody here has it. None of my patients have it. Nobody in the US, as far as I know, has it. Which means everyone in here is capable of sleep. But sleep hygiene takes 2 to 3 weeks of practice, of daily vigilance, of doing the same thing day after day. But you will sleep. Your body will sleep because it needs to survive. Taking a pill, telling yourself it's okay to take a pill just because I don't feel like doing the work, that's addictive. Avoiding recovery-related activities. If you know an addict who's actively using and you make a suggestion to them and they absolutely don't want to do it, that's probably the thing that's going to help them. That's the nature of the addiction. The addicted brain does not want to get well. And so as a family member, you often are stuck in the position of hearing, I know my body better than anybody. I know what's going to work for me. That's not going to work for me. What they're telling me isn't for me. I'm different, I'm unique, I'm special, and if I do it my way, it'll work, and you just need to support me. And then they fail, and then you feel bad, like I did something wrong. And this is the reason punishment is not effective. Punishment doesn't fix the cortex. The cortex is weak. It's a weakened Superman, right? The midbrain, there's nothing we can do about. The midbrain's broken. We broke it. It doesn't go, once a cucumber's a pickle, it's never a cucumber again. So once the midbrain is addicted, once it has this dopamine receptor problem, it's never fully normal again. The receptors come back, and it does function normally again, but it's a friable organ. It never goes back completely to normal. The cortex, however, we can fix, and the cortex is what we need to work on in treatment. Send somebody to prison for 5 years for a drug-related crime. You take away their drug, let's say they don't have the motivation in prison to get their drug, and so they don't use. And so their midbrain quiets down because they're abstaining. But the cortex never gets any work, so it's still weak. They get out of prison, and they're like, I'm not going to use, I haven't used in 5 years, I feel fine, I don't need drugs. And then they're like, oh, my girl left me, or my husband died, or something happens a month later, and they still don't have a coping skill because nobody in prison gave them a coping skill. And so now they don't know what to do, and the brain, the tiger wakes up and goes, oh my God, we're stressed, and stress means we're dying, and so therefore we need more dopamine because that's how we live, and the only way I know to get dopamine is to use. And then suddenly that person who just spent 5 years in prison for a drug-related crime is using a month after they got out. And we're all going, what are you, an idiot? And they're like, oh, I couldn't help it. And they couldn't. So the idea in addiction treatment is to fix the cortex. That's across the board. That's what we want to do for everybody. Okay, whether we use a medication or we don't, everybody needs the cortex restored. That's how you fix addiction. So after we detox people, and detox is really important, but for our purposes tonight, I'm not going to go through it. But essentially, if you drink alcohol or you take benzodiazepines, and benzodiazepines are Xanax, Ativan, Valium, Klonopin, Soma, anything that ends with ZAM, right? Alprazolam, midazolam, all those. Those are just alcohol in a pill. That's all they are. Chemically, they're the same as alcohol. And so essentially, you can become addicted to them, and you can die coming off of them, just like you can die when you stop drinking. If you drink every day for a week or more, please don't try to just stop. Not without help. You can have a seizure and you can die. Opiate withdrawal doesn't kill anybody, but it feels like they're dying. And people who are in opiate withdrawal generally can't tolerate it for more than a couple of days. They go out and they use to fix the symptoms, and they use as much as they had previously, and they overdose and they can die. So people do die in detox. Okay, so that's a medical stabilization. But once they're stabilized, now we have to work on fixing this cortex. So one of the first things we have to do is we have to figure out how to convince this midbrain it doesn't need all this dopamine to survive. So how do we do that? The only way to do that is to either give it what it wants, more dopamine, or take away all the dopamine for a period of time. Then what we have to do is we have to help strengthen the cortex. We have to strengthen Superman. We have to take away this sense of self that is associated with using. Anybody remember the show Cheers? Right? When Norm walks into the bar. Norm, right? That's his life. That's his identity. He identifies himself as a bar stool. That's his whole life. And addicts are the same way. Over time, their life becomes totally entrenched by the culture of their using. One of the most amazing phenomenons I ever see, and I still get a kick out of it. Go to a detox unit anywhere, and you will see that the alcoholics think they're better than the addicts because they only used alcohol. And the addicts think they're better than the alcoholics because they're more badass and they use drugs. And the people who use needles are more hardcore than the ones just using pills, and the ones using pills are better because they never got as bad as the ones using needles. This is truly how people, this really goes on. You can see this sense of ego and pride associated with the wrong stuff. But this is who they are. It's who they've become. Their sense of identity is so wrapped up in their using and the culture of using because their frontal cortex is so weak that they have no other sense of self. And so we have to give them these things. We have to give them coping skills and stress relief and safe environment. One of the things I hear all the time, which frustrates me, is EMTs tell me they go out and they find someone overdosed on opiates, and they give them Narcan, and they bring them into the ER, and the ER stabilizes them and sends them home. And 2 hours later, the EMT gets a call on the same person in the same house because they overdosed again, and they're frustrated. Well, what did you think was going to happen if you send somebody back to the exact same place where they were using and overdosed? Of course they're going to use again. Glutamate won't let them forget how awesome it was before they fell out. And then the other part, and the more important part, spiritual growth and personal development. It's absolutely necessary. And people get real squeamish when you talk about spirituality, which I don't understand, because it's not religion. I'm not talking about religion, and I'm not talking about God. I'm talking about spiritual growth. Spirituality occurs in the cortex in a totally different part of the brain than religion does. They do communicate if you want them to, but they don't have to. And so here's how spirituality works. Spirituality is your sense of self in the universe. What is my purpose in life? Is there anything out there bigger than me, or do I control the universe? How can I be of service to people, to others, to the universe, whatever? That's what spirituality is. That's what addicts need to develop if they want to get well. And the way this works is, I always say, let's pretend that I go to the gym every day. It's a stretch. And let's pretend that while I'm at the gym, every day, without my trying or thinking about it, I automatically work out my triceps, the back of my arm, for those of you that don't go to the gym every day like me. So I'm working out the back of my arm, my triceps, without thinking. No effort, that's what I'm doing. I'm doing dips, I'm working out my triceps. Eventually what happens is my arm gets stuck straight because my tricep is so strong and I never bothered to work any other muscle. So in order for me to counteract that, knowing that my arm is going to work out that tricep every day, is to put vigilant effort every day into working out my bicep, which would be the opposing muscle for my anatomy friends. So if I'm working out the opposing muscle, I can keep them in balance, right? There are days where I don't want to work out my bicep. I don't want to focus on my bicep. I don't even want to go to the gym, but I know I'm going to because that stupid tricep's going to be working. The tricep is the midbrain. It's where addiction is. It's always there. It's always working. Once it's occurred, it doesn't go away. And the only way to counteract it is with daily work on the cortex. That's the bicep, the cortex. So when people say, well, I don't like to go to meetings because I don't want to be reminded every day that I'm an addict, well, sorry, but you have to be. You have to be reminded that there's addiction in your life, that you have a disease. That's like a diabetic saying, well, I know I should take my insulin, but I don't want to be reminded that I'm a diabetic. You are. You have a disease. It has to be treated every day. So the idea is that behavioral therapy and traditional 12-step meetings work in the frontal cortex. That's what they do. They are effective. They are great treatment modalities. The problem is, some people can't get past this midbrain problem. They can't get past this craving problem. They're overwhelmed by this angry tiger. We still have to work on the cortex. That's still necessary. But sometimes in order to do that, we have to go to the midbrain. And the midbrain is where we use drugs. Drugs of abuse and drugs as in medications. Why do we use medications that work in the midbrain? Because drugs work in the midbrain. So the idea behind traditional 12-step groups and traditional residential and IOP therapies is to take a weak Superman, make him strong in the face of a craving midbrain. So 80 years ago, when Alcoholics Anonymous was founded, you had a bunch of older gentlemen who had lost jobs, careers, wives, houses, cars, everything. Sometimes twice. Sometimes they lost everything, stopped drinking, gained it all back, and lost it again drinking. So when they walked into a room with a bunch of other older men who said, sit down, shut up and listen, we're going to tell you how to get sober, they said, I'll do whatever you say, I'm desperate. I've lost too much. Today, we have 19-year-olds who have lost a job at Taco Bell, and mom won't let them use the car anymore, which is kind of devastating for them in their world, but there's no desperation. And without desperation, how do you get that person to sit in a room full of other old men who tell them to shut up and listen when their midbrains are going, I'm dying? So the idea behind the 12-step programs, the idea behind this therapeutic intervention for the cortex is that 12-step programs are spiritual growth for dummies. That's all they are. It's literally 12 steps. You work through them one at a time with somebody else who's done them. And that's it. That's your bicep workout. There you go. Easy breezy. Nothing to it. And how do we know it works? Because most addicts don't want to do it. Counseling is really important. Group therapy, more so than individual. Again, why? Most addicts want to do individual. Why is individual counseling not effective for chemical dependency on its own? Because I don't care how good of a counselor you are, you cannot out-manipulate an actively using addict. However, a group of other addicts cannot be out-manipulated by an actively using addict. So group therapy, very effective. So once again, addict likes one versus the other, you can guess which one they want. Over time with abstinence, this will come back to normal. However, it is friable, it's weak. This means once the damage occurs, it may have taken 10,000 uses for that damage to occur, but now it only takes one for it to move again. So over time, this will come down, but one use, go to the ER, I'm having a panic attack, get a shot of Ativan, right back up. This could take a year. Could you imagine a year of not being able to experience any pleasure? This is why most addicts don't make it more than 6-7 months if they're not doing anything else. White knuckling it. I can do this on my own. I'm just going to focus on work and school and my family. Nope, you're going to use because they're unhappy. If you work that bicep, if you work on spirituality, if you throw yourself into some kind of personal growth program, this can happen in as little as 3 months. And if you use medication, medication's purpose is simply to quiet the tiger when Superman is weak. So this is that 19-year-old who has serious midbrain problems, no desperation, and no coping skills. And we say, go to a meeting, and they're like, no, I'm not going to a meeting, I want to use. So the idea is, how do we quiet this tiger? And the answer is medication, because drugs work in the midbrain. Now, would I give medication to somebody and then ignore their cortex? if I was an idiot, if I didn't care, if I was just trying to make money maybe. But if I want somebody to get well, I may not be able to get them to work on their cortex. I may not get them to get into a meeting unless I quiet that midbrain, unless I give them something to help. So anybody that thinks I'm going to go get a shot of Vivitrol, I'm going to go get on Suboxone, I'm going to go get on methadone, and do nothing else, they will fail. Sometimes it takes years. They will fail. But if they want to do those things in conjunction with group therapy and meetings and working a thorough program, they can do really well. They can succeed, and they may succeed more so than if we hadn't given them the medication. So the definition of addiction is essentially dysregulation in the midbrain, in the pleasure system, due to the unmanaged stress that results in loss of control, which is acting like a fool, right? Stealing, lying, manipulating. Craving, which was that overwhelming, suffering tunnel vision. And persisting use despite negative consequences. Gotta have negative consequences. If there are no negative consequences, why would you stop using? I don't know. So, the organ is the midbrain. The defect is this dysregulation of the dopamine reward system. And the symptoms are this loss of control, craving, and persistent use despite negative consequences. In cancer of the liver, the organ is the liver. The defect is an overgrowth of liver cells, and the symptoms are liver failure and difficulty making platelets, etc. It's the same thing. It's a disease. It's a neurological disease. And really, the best treatment is this kind of ultimate toolbox, a combination of medication and therapy and groups and 12-step meetings or any kind of spiritual growth. If you want to go live with the monks in Tibet for like a year and do some spiritual growth there, that probably would work. But if you don't have the time or money for that, you can do an hour a day at a 12-step meeting and get the same thing for free. So the idea here is this, and you know, a lot of people want to ask me about medication. Well, isn't that just substituting one drug for another? Yep, it is. We're quieting the midbrain with it, you bet. Because I need to work on that cortex, and I can't get my hands on it if that tiger is there guarding, right? And isn't it just a crutch? If I give somebody methadone, isn't it just a crutch? You bet. If I break my leg, you better give me a crutch. I got to take pressure off of that broken leg so it can heal. And some people wind up in a wheelchair. They never get better, right? Most people heal. But while I'm on crutches, I got to go to physical therapy. I got to go see my surgeon. I got to follow all my doctor's instructions. But I still need the crutch. And that's what the medication does. It allows you to take pressure off the midbrain so you can work on the cortex. And I put this in here because everybody likes to ask this question eventually. What about marijuana? Look, I don't care about marijuana any more than I care about alcohol, unless you're an addict. If you're an addict, marijuana is off the table. Marijuana works in the midbrain and it releases high-level dopamine just like every other addictive drug. I'm sorry. My addicts love to say, I can't wait till it's legal in Ohio. And I say, why? You can't have it. It's not for you. It's for other people. If you're not an addict, I'm not going to tell you not to use it any more than I would tell you not to use alcohol, right? It's a risk. If you have the gene that's turned on by 7 uses of marijuana, you smoke pot 7 times, and then you get 1 prescription for Percocet, and it's too late. You're already addicted. You didn't know. But, I mean, everybody has the choice, right? But marijuana is off the table for addicts. It's not an option. Everybody likes to think, I'm going to stop shooting heroin, and I'm going to smoke pot. I'm going to use the marijuana maintenance plan. It doesn't work. It has 0% effectiveness. And addiction is a family disease, and it is a family disease not because they steal from their families, and not because mom and dad are sleeping with their car keys in their pillowcase. It is a family disease because family members focus on their addict the way their addict focuses on the drug, which makes the addict their drug of choice. Same disease. Same disease. Codependency is addiction. It's just the person is the drug of choice. And if you're spending all of your time and energy thinking about that person, worrying about that person, are they going to die? Where are they going to get money from? How am I going to prevent this? How can I fix them? How can I get them into treatment? I'm going to go talk to that doctor after this thing, and I'm going to ask her what my son should do because I need to fix him. right? Codependency. Go to Al-Anon. Go work the same 12-step program as the addict, because it's the same disease. And the answer, and the truth is, we're not ever going to treat this disease to extinction. We're never going to get rid of it. So our best bet is simply to try to prevent it. I don't know how we do that. My best guess is, let's take the skills we're giving addicts when we're getting them clean and give them to children before they ever use. Teach them how to become spiritual. Teach them coping skills. Teach them stress management. Don't assume because a child seems well-adjusted and able to deal with what they're thrown that they are dealing with it, because that may be translated to neglect and trauma. And that may, in turn, decrease their dopamine receptor availability and put them at risk for addiction, right? So that's my best guess for how we do this. But the American Board of Addiction Medicine calls addiction an adolescent disease. Most people try their first high-level dopamine substance before the age of 12, so at least once. So prevention is really where it's at, but I don't have the answer for that. So I think that's it, and I think that we're going to do questions, right? Yeah, I'll stand at the podium. It's very sweaty.
Before we start, I want to talk about this. Okay, before we start questions, someone lost their key card, and if you'd like to go to sleep tonight, please come get that from me.
If not, we'll sell it.
If not, yeah, you're right, we'll sell it. I need tuition money. Okay, well, questions. Raise your hand so I can come to you. Give me a minute, my feet hurt.
Mine too.
It's been a day.
Dr. Labor, I've heard you speak before, but I think what is so impressive to me is your own journey. Would you be willing to share that with the audience?
Sure. People ask me all the time why I am in addiction medicine. Why would anybody choose this field? It's a good question. And the primary reason is because I myself am in recovery. I just celebrated 12 years without a drink or a drug. Thank you. But, there's nothing really special or specific about my story. I had a normal childhood. I did suffer some trauma and abuse as a child that I didn't appropriately deal with. But essentially, my parents were good parents. I grew up in suburbia. I rode my bikes outside. We didn't have the internet. And, I was a really good student. I did very well in school. I always tell people my first signs of addiction were in kindergarten, when I realized that if I lied to my kindergarten teacher about how I was feeling, I got extra attention. I learned how to manipulate. I learned that if I told my mother I was fine, then she didn't get upset. And so I didn't really have to worry about her feelings anymore. And I was just really a sensitive person, really overly sensitive. And again, on the outside, if you ask any of my family members, they'll tell you I was a super good kid, well-adjusted, seemed strong, independent, dealt with whatever came my way. And so hearing that, I believed that, and that's who I wanted to keep being. And so I never bothered to look at whether or not I was actually coping with life appropriately. So when I had my first drink, I was 12 or something like that. I was drunk. In the first time, we were just experimenting. And then, as time went on, more and more as drugs came my way, as long as I continued to do well in school and be high functioning, and as long as my friends were doing more drugs and causing more problems in their lives than I was, then they were the ones with the problem and I wasn't. And so by the time I was in my third year of medical school, I was shooting dope every day. And I couldn't take it anymore. Obviously life gets so crazy and stressful and horrible, so I wound up breaking down and turning myself in. And then the state said I had to go to treatment, and I was like, you don't know what I need, I know what's best for me, right? And they said, well, if you want a medical license ever to practice medicine, then you need to do this. And I said, well, maybe I don't want to practice medicine, but I had like $200,000 in school loans and no way to pay it back, so I thought, well, maybe I'll give it a shot. And I went and I did my inpatient, and it took me a year of going to meetings and just kind of spewing out what they wanted to hear and never internalizing anything before I started to realize something's got to change, because I'm pretty miserable even though I'm not using, and I don't know how long I'm going to last. And so I started really engaging and going to meetings. I got a good sponsor. I did everything they told me, and that's really what it came down to. My stubborn ass had to do everything I was told. I don't like that. I want to analyze it and tell you why it's not going to work for me and it's different for me and I'm special and unique. I really want to do that. But my experience is this. This program will keep anybody clean 100% of the time if you take 100% of the suggestions and not the easy ones, the ones that are hard. You're going to have to quit that job. How am I going to pay my rent? I don't know. But if you keep working there, you're going to use. Fine. You got to get out of that relationship. But I love him. Well, that may be, but you're going to use. Fine. That's the stuff I had to do, you know. And again, you know, so I get clean. I repeat my 3rd and 4th year of medical school, go to residency, and here I am practicing addiction medicine, you know. So, I mean, that's how you get from A to B. So anybody that thought there was no hope, I mean, there's definitely hope. I was living under the bypass in the back of my car in Newark, New Jersey, because that's where the best dope was at the time. You know, that was my life. And here I am, the associate medical director or medical director of 5 different facilities. People pay me, I am far, far over educated for what I'm really capable of. So, you know, but it can be done. Anybody can do it. I am not special or unique, and there is nothing about me or my story that, you know, couldn't be anybody else's, which is why I'm always fascinated when people say, can you share your story? Because I'm like, I can, you know, but essentially it's, I did drugs for whatever reason, it doesn't matter. I don't have to know why I'm an addict to fix it, right? I don't have to know how to make a donut to eat a donut. So I used drugs. My life was a mess. I made a decision to fix it. I took direction from people I didn't really like. And now my life is better. That's it. It's really as simple as that. It doesn't have to be more complicated than that, you know, but it does involve taking direction. And we're not good at that. Addicts are not good at that. So that's the shorty version of my story.
Any other questions?
I have an 8-year-old son, and you brought up something about not knowing about future prevention. And I just want, from a medical standpoint, I deal in addiction and I sponsor a lot of people. And I see pretty much the foundation in everyone's story is the same. They started with resentments at a very early age. And 2 things that I've also heard in private schools now is mandatory drug testing. What hoops need to be gone through to start mandatory drug testing 3rd and 4th graders regularly, along with help to deal with and prevent future resentments? Because those are the 2 recurring themes I've seen. Is I've experimented at an early age, and I had a ton of resentments that were not dealt with, and then I started using heavily, and the resentments just piled up. With those 2 things together, maybe at an earlier age, along with obviously educating our youth and not sugarcoating it, and letting them know the dangers of even one use. Because I'm sorry, my son's 8 years old, and I keep it straight real with them. And I think not educating them and sugarcoating it is actually hurting our youth. And I just want your opinion on that.
Well, first I will start out by saying I am not an interventional adolescent person. I don't know, I'm not an adolescent specialist, okay? So I'm not gonna talk about adolescents like I know everything about their brain development. So there's something different going on there. My suggestion, and I've met with schools about this as well, but my suggestions are, I mean, there's a couple of things. One, mandatory drug testing, that's going to have to be district by district. I don't think you're ever going to get any kind of regulation, you know, but as parents, I think you can be involved in your school district to ask for that or to request that. There are some schools that do it, mandatory. I don't know if it's that young, but there are some. And it can get done, and it can be helpful in detecting early use and therefore helping. As far as early resentments, I agree, but I think a lot of that is going to fall on parents. The question needs to be, how did you as an adult deal with those resentments, and how can that be translated in a way that an 8-year-old can understand it? So how do you teach them to deal with resentments at a young age? I don't know that that's something that the schools have to do. I think that's something that parents probably have to work on. And again, taking like this, I'm sitting down with an adolescent specialist in the next few weeks to take this information and slide by slide, bring it down to a level that's understandable by different age levels, right? So I think doing this, taking a 12-step program and translating it back into something that's age appropriate might be beneficial for a kid. To teach them steps 1 through 12, but in a way that's age appropriate. I think that could be done. And I think a big part of our problem, and I heard this from a superintendent of schools, is that, unfortunately, we're teaching a lot of our children, they have no grit. They have no ability to withstand any kind of stress. And so teaching them kind of that endurance and resilience, and teaching them that life's going to hurt you, you're going to fall down, you got to get back up, you got to keep trying, and you don't have to run from it, or you don't have to hide from it, and you're not going to get a trophy all the time. No Child Left Behind and giving away trophies. I'm not a specialist, so maybe that's great, but in my experience, that is the worst thing for addicts. Because all we're doing is enabling people to believe they're entitled to something that they're not. And so when they don't get it, and they have no other coping skill for it, and they find out that drinking makes them feel better, they're going to drink. That's what we as humans do. We seek out the most pleasurable or self-soothing experience. So teaching children how to self-soothe, I think that's paramount. If they know how to self-soothe and relax and decompress without needing a chemical, then when the option comes up down the road, maybe they won't choose the chemical. And especially if you're an addict in recovery, your kid has the gene. That's it. So they need to know. I know a lot of addicts say, oh, my kid's never seen me drunk, and they're never gonna, and we don't talk about it. That is the worst possible thing you could do for your child. You have the disease, talk about it.
Okay.
Oh, I'm pointing like I have the microphone.
Where are we pointing at?
Well, there was one over there, one over there.
Okay, we'll go over here because it's a little closer.
I was wondering if you could speak to non-substance abuses, for example, gambling. Is the science behind that the same, or is that different?
Process addictions, so process addictions are the behavioral addictions, workaholism, gambling, shopping addiction, sex addiction, porn addiction, et cetera. Anything that there's an A meeting for, an anonymous meeting for, those are your process addictions. And the way that those work is actually, I'll show you. So the process addictions release dopamine somewhere in this level, right? So it's not quite as much as drugs, but it's more than normal activity. So what winds up happening often is as this threshold starts moving down, somebody starts gambling or having compulsive sex or shopping, and they realize, oh, I kind of feel better, I kind of feel normal, kind of feel good, and they start doing that compulsively, and then the threshold stays there. Because it's like, all right, well, if this is how much dopamine we're going to get, this is what we're going to do. And so it kind of gets stuck there, and so they're still sort of stuck in this same problem. So if I need to, exercise 4 hours a day just to feel normal, what am I going to do when my mom dies or my dog dies? Obviously, I'm going to still need more dopamine, and so I'm going to go back to the original. And so they wind up going hand in hand, So, and again, they're treated the same way, same 12 steps, just for each specific. And obviously some of them are, Food Addicts Anonymous, you can't just not eat. There's very specific rules. Sex Addicts Anonymous, same thing if you're in a relationship. So, there are specific rules, but the treatment is the same. It's spiritual growth, which will bring the threshold down. Yeah.
Okay, there was a question over here.
Oh,
Wait, okay, I'm going to go to him first real quick because he's just a little bit closer.
if I put a laser on people, does that
You
count?
just want me to do that?
So there seems to be controversy inside the recovery treatment grouping about the different medications, Suboxone or
Yeah.
Vivitrol,
Yeah.
and real controversy over you should use none of the drugs, it should just be the 12 steps.
Yeah.
What's your response to that issue?
Well, I certainly hear that all the time, and my response from a medical standpoint is it's really nobody's business what medications I'm on or what anybody's on. If that's part of your medical treatment plan, that's part of your medical treatment plan. So if I have somebody who's tried 50 times to walk into the rooms of Alcoholics Anonymous and has not stayed clean for more than a week or a month, but they come in and they get put on Suboxone or methadone and they manage to stay clean for several months, and they're going to meetings, and they get a sponsor, and they're doing what they're supposed to, I don't understand why that's not okay. And people have their, I mean, I understand why people think it's not okay, but I'm saying, from my perspective, you know, the idea is like, I thought we were just trying to save lives. If somebody is a diabetic and they refuse to check their blood sugar and take their insulin, and they show up in the ER 47 times a month, do we say, well, nope, this is your 45th time, sorry, you're gonna have to go home and die? No, we take them in, we treat them, and we re-educate them as much as we can, hoping one day they're gonna go home and say, you know what, I really should pay attention to my sugar. You know, so I think the same is true as far as medication goes. I don't think it's anybody's business but the person on it, and if they have a sponsor, their sponsor obviously has to know. As far as the individual, you know, Vivitrol versus blocking versus replacement, again, that's really individualized. I mean, Vivitrol is a blocker. You put it in, it completely blocks opiates, right? So you can't get high, you can't experience euphoria, but you also don't get any of the dopamine that you get from the replacement drugs. So it seems glorious, right? Why would a chemical be the treatment for chemical dependency? It's just another tool. That's all it is. So people, and again, what I have is addicts going, well, I want to get this shot and then never do anything else. I don't want to go to meetings. I don't want to go to groups. Why do I have to? I can't get high. And I said, but you can take benzos. You can use cocaine. You can use but I don't like that stuff. Well, let's see how quickly you like that stuff when I take your opiates away. You'll like it quick, you know. So the idea behind the medications is I think that they need to be used responsibly by physicians who actually understand addiction and who have it in your best interest to get you to the groups, strengthen that cortex. The purpose of the medication is just to take the pressure off the midbrain. You know, it's not appropriate for everybody. And again, if it was, we'd have one pill to rule them all. What do you do for cocaine addicts? There's no medication for them. You know, what do I do for Xanax addiction, or people who are dependent on Xanax? I got nothing for them. You know, so I have something for opiates and I got something for alcohol. Sometimes they help, sometimes they don't. You know, so it's really individualized, but I don't think that people need to be taking this to the streets and telling people. I go to a lot of NA and AA meetings. I've never been to a meeting where someone walked in and said, hi, my name is so-and-so and I'm on Synthroid for my thyroid disease, and I'm on, you know, metoprolol for my high blood pressure, and they want to talk about, it doesn't work that way. It's nobody's business. There's no reason for you to walk into a meeting and say, I'm on Suboxone or methadone. There's no need for it, because you're there to talk about your experience, strength, and hope. So you're there to talk about how crappy your life was because of your using. You're there to talk about how you deal with your emotions and your problems today. And I hope it's not, I take a pill, because if it is, you need to be there, you know.
I'm over here now. Okay.
Hi, I was just wondering, because I'm still kind of confused on, so is it do you have to have the synapses to for the dopamine, or how, okay, I'm confused. Okay, let me English real quick. So, if I was to smoke weed and I felt good, is that because it's making me I'm doing something that I think is a good thing, is making the dopamine go, or is it that I'm predisposed that if I do something fun, dopamine is going to come out?
Anybody, all humans, if you do something that binds to a neuron that releases dopamine, is going to release dopamine, and then you're going to enjoy it. That's it. That's all humans. Now, some humans will say, I use Percocet and I don't like it, but it still released dopamine. You just didn't like the effect the dopamine had on you, but it's still dopamine. So if you smoke pot and you like smoking pot, then you're normal. That's a normal response to using drugs that people abuse, right? Because it binds to this neuron and it releases dopamine, and the dopamine binds over here. All neurons have vesicles with dopamine, and all receiving neurons have receptors for dopamine. It just depends on how many are there, tells you how much you need. So like, let's say all these little tiny things in here are dopamine, right? They're all dopamine. Let's say there's only 2 of them in here, and then these are all receptors. Well, then only those 2 will bind, and it won't be as pleasurable as if there were 5 receptors or 5 dopamine molecules, right? That's more pleasurable. Now there's 1 billion of them, and then so as this one binds and then it releases, a new one jumps on and then it releases, and so it lasts longer and so forth. But anybody, if you do something and you enjoy it, it's because it released dopamine. That's all.
So it's like by choice. So like I don't like, not me personally, I'm just saying like I like
For a friend.
alcohol. Yeah, speaking for a friend. I like alcohol more than smoking marijuana.
Sure.
So there's that choice where you just choose it, but then based on your gene, it will inhibit where you get the addiction because of that.
Yeah, your genes will tell you whether or not you become addicted. You may not have a gene for either alcohol or marijuana. You may have a gene for addiction that's crystal meth, and you'll never use crystal meth, so addiction won't be a problem. But if the dopamine release from alcohol or the dopamine release from marijuana, it binds to this neuron, and it causes an effect. The effect from alcohol is more pleasurable to you. Just your interpretation of that dopamine is more pleasurable. That's all it is.
Okay.
It's a subjective or brain interpretation, but it's the same process. So that's the idea, is if you remove the you part of it, it's the same process for every drug.
Thanks, that helped.
Sure. Tell your friend I'm praying for.
Okay, I think we have like time for one or two more because we don't want to go too late. Well, no, he had a question. So.
So we see a lot of like new pharmacopsychotherapy with just like treating addiction. Like, you know, we're giving the examples of Suboxone and other, you know, of these substances that, you know, they are psychoactive in certain senses to, you know, change and mediate these behavioral impacts and allow us to, you know, work on our, you know, our cortexes, like you said. So, you know, what do you know about like substances like ibogaine, which, you know, this pharmacological substance that works on like all the opioid receptors. It antagonizes NMDA. It also has very strong affinity to sigma receptors, as well as the 5-HT2A agonists, as well as, you know, so it goes through that whole spectrum. And from case studies that they've done in places like New Zealand, they've shown that one treatment of ibogaine, you have this psychoactive experience, and if someone is like full-fledged addicted to heroin, they are not after one time of using it. And then also, you know, is there any potential to create new drugs that would, let's say, help to mediate the midbrain, increasing dopamine, you know, D2 receptors in our midbrains and other senses like that? Like what do you know about that?
Okay, so for the latter part of that question, they try. They're looking into drugs that might be able to regulate dopamine in the midbrain. They haven't been successful in finding anything that is able to cross into that area and have any kind of effect. I mean, obviously, anti-Parkinsonian drugs deal with dopamine specifically, but it's a different area of the brain. So it doesn't really seem to be able to gain access into the midbrain. So they haven't been really successful. And to be perfectly honest, they're not going to put a lot of money into it, because it's not going to get them a lot of money. As far as the studies that are done in other countries with different medications, I always take them with a grain of salt, and I think I read the one that you're talking about, and I do think that there's some like solid theory behind it, but I don't think that the sample sizes are generally large enough to really translate to be able to say, yes, this is appropriate. And once again, United States is, you know, as far as what the FDA is going to prove and we're going to allow in this country to be used, I mean, it becomes irrelevant. There's no such thing, though, as not being addicted anymore. It doesn't happen. It's not physically possible for it's like somebody drinks alcohol for 40 years and their liver's fine. And then one day they wind up in the hospital and their liver enzymes are really high because their liver's failing. They stop drinking for 2 weeks and their liver enzymes go back to normal and their liver looks normal. But then a week later, they're back in because they drank once, and their liver enzymes went up again, right? So that liver is friable, meaning it can go back to normal and function normally, but as soon as it takes a hit, it took 40 years the first time for it to show any kinds of weakness, but now it only takes one hit in order for it to look bad. That's what happens in the midbrain. It becomes friable. So there's somebody can use a drug and then come out the other side the next day and say, I don't have a craving to use today.
Yeah.
But that doesn't mean they're not addicted.
Okay, and then so you know, we say that it's activated. You know, these genes are activated,
Yeah.
and that it's downstream effects that are reducing dopamine receptors. So what about if we were to mediate, you know, downregulate these like their FOS, you know, those sort of pathways to like the genes that are like mainly associated with addiction?
Great. Are you working on that? Awesome.
Potentially.
Yeah, awesome. Go ahead.
Cool.
Yeah,
Right, well, thank you.
I'd love to see somebody doing genetic research on addiction. Nobody cares. Nobody's going to pay for it.
There's
If you
a lot
want to,
of-
I mean, if you have like a trust fund and you want to spend your time doing genetic research, that'd be awesome. I will help you, but I don't know anybody else that's going to do it. They are looking at the different genes, but they're finding that they're so versatile, they're so different in structure that it's almost impossible to identify all of them. You can identify some main genes, but family history is really your best guess.
Most definitely. All right, thank you.
Sure.
Thank you. We have time for one more question. I'm going right back there.
I'll wait around after
she can
if
ask
anybody has
afterwards.
questions.
We got some other stuff to wrap up, though.
I'll wait outside.
So I don't know if you had said this during your presentation, but when you talk about getting the dopamine threshold to go back down again, so I would think that while that's high, that would be at the highest time of relapse. So how long does it take normally, on average, to reset that dopamine threshold?
A year. A year with abstinence. A year with abstinence and nothing more. But if the more wholeheartedly you throw yourself into strengthening that cortex, the quicker that process will occur. So I usually say, one of the reasons, and they didn't know this obviously at the time, but one of the reasons they recommend 90 meetings in 90 days is because we know that if they throw themselves into recovery that wholeheartedly, that process actually occurs a lot more quickly. So I think that's the issue. So